Good afternoon, everyone, and welcome to the Georgia Center for Diabetes Translation Research webinar sponsored by the Center's Socio-Ecological and Behavioral Science for Equity Core. I'm Dr. Tabia Akintobi, Professor and Chair of Community Health and Preventive Medicine, and I collaborate with others across Emory University, and particularly Dr. Thomas Godfrey, who co-directs this core with me, and others at Georgia Tech, with a constellation of partners across Georgia and beyond, to lead a core that is designed to support and facilitate ethical recruitment, retention, and sustained engagement of community and patient population groups in health promotion. And we also look to promote related research methods. For more information about the Georgia Center for Diabetes Translation Research, I'll ask Jeff, who is our fearless leader, day-to-day leader of the center, to include the website to the Georgia Center for Diabetes Translation Research, where you can learn more about becoming a member and about funding opportunities. So thank you for being with us this afternoon, depending on where you are. I'm really very, very pleased and honored to introduce today's featured speaker. We're so glad that she said yes, Dr. Nina Wallerstein. She's at the University of New Mexico and is a distinguished professor of public health and directs the Center for Participatory Research within the College of Population Health, contributing to community-based participatory research and empowerment for over 35 years. Among 180 publications, her book, Community-Based Participatory Research for Health, Advancing Social and Health Equity, it was in its third edition in 2018. It's viewed as a field-defining work. In 2016, she was awarded the inaugural Community Engaged Research Lecture. Since 2006, she has had NIH funding as principal investigator with national partners to test measures and metrics for partnering processes and outcomes, identifying best or promising practices for community engaged research and community-based participatory research projects that contribute to health equity outcomes. And she also, I will talk a bit about her Engage for Equity collective. I'm really excited that beyond being a big fan of hers when I was working on my dissertation a couple of decades ago, that she has become a trusted partner and collaborator in all the ways that we advance health equity through community engagement processes that are rigorous and have established impact and metrics. Dr. Wallerstein, thanks for being with us today. And we look forward to all of your engagement in this important discussion. Please do include your questions in the chat. Dr. Escofri and I will be monitoring those closely so that there's some time at the end of Dr. Wallerstein's talk to engage with you. Dr. Wallerstein, we welcome you and thank you so much.
Thank you so much yourself, Dr. Akintobi. I am really pleased to be here. I am pleased to be a partner with you at Morehouse, and I'm just pleased to kind of extend a discussion on what are core community engaged practices and how do you measure, evaluate, and understand them to really look towards the best that we can be and work towards this really hard time we have now in confronting racism and other inequitable discriminatory practices in our country and how community engaged research can make a difference. So I'm going to just put up my slides, see if I can do that right here, and take you through with me just to kind of set the stage, talking about, yes, metrics for evaluating best practices to strengthen outcomes, but for the purpose of health equity. And I'm just going to go quickly through kind of some introductory information and then launch into our Engage for Equity work and measures and metrics and outcomes that we've seen. So first, who I am. I always like to start with my parents and my grandmother who immigrated from Russia and Berlin Jewish immigrant family, raised in social justice. I had a lot of privilege in terms of middle class, as well as resources, intellectual capital privileges, but I've also experienced anti-Semitism, and I understand a little bit of that kind of oppression as well. I was in the 60s part of the anti-war farm workers, women's movements, and keep going on to in the academy. To me, it's important to know who I am because I've worked primarily in my own CBPR work with Native communities. I've done CBPR culture-centered tribal intervention research and have to always kind of think of myself as how to best be an ally within that work, even though I come from a very different community. Paulo Freire has been an important distant mentor of mine, and I've worked a lot in Latin America as well. And I'll be talking today about this Engage for Equity work, which I consider both a science and an art, but also of politics and policies of what does it mean to adopt promising practices. So starting points for me that we should not hurt the people that we study. And then a Freire quote, to be a good educator means above all to have faith in people and to believe in the possibility that they and we can create and change things. So the Kellogg definition, of course, is the most recognized definition of CBPR, beginning with a research topic of importance, combining knowledge and action for social change. But I've been working a lot in the practice community lately, and it might not be an intense NIH grant, but any collaborative effort that involves research and data to build on strengths and priorities of the community can be partly foundation funded or just CBO directed, using multi-level strategies to improve health and social equity. How do we bring our same collaborative practices to this? And of course, there's long histories of research distrust, but I love this little quote, keeps me honest. Researchers are like mosquitoes, they suck your blood and leave. And how do we not do that is my core question to myself all the time. So we've worked for many years at the University of New Mexico to move from a engagement on or in communities to the use of the term with, and how everything changes when you use the term with communities. So a set of principles that you all might know, of course, with cultural humility in the center. But since from my work with tribes, I've really learned, this is where I cut my teeth in CBPR, the importance of recognizing tribal systems as their own sovereign nations, and how to respect and honor these systems means that approval goes through the government, goes through the leadership, and that tribal specific data shall not be published without prior consultation, and that all data belongs to the tribe. This is very different than universities normally think of data, but it means that we have to think about these principles, not just for tribal sovereign nations, but for every single community that we work with. How can we have the same ethical guidelines and responsibilities? And that's where I've learned, and that's where I've come from. Also recognizing when I can bring my own power and privilege to the game, how do I use that in a beneficial way towards authentic partnering? So yes, there's been a new model that you've probably now all seen from NASEM, or in the National Academy of Medicine. I've been part of the creation of this model. And to me, what's beautiful about it is it has a set of 4 petals of really important outcomes of our work: strengthened partnering and alliances, expanded knowledge, improved health and healthcare programs and policies, and thriving communities, embedded in a list of principles. The model that I'm going to bring to you based on our work is different in that it's complementary, in that it shows a pathway of how things can change. So accepting that this is a beneficial new model to help identify and commit to a set of outcomes, I'm going to take you to our work for Engage for Equity and show an idea that's really important to me, which is what are the practices and processes that make a difference as we go forward, and how do we create and measure pathways to change? So Engage for Equity, I think Dr. Akintobi mentioned this word, is the name of our long-term 2006 to present NIH funded. We've had 3 stages of NIH funding, and now we're in a 4th stage of PCORI funding, where we developed initially our conceptual model with NIMHD funding through a NARCH, Native American Research Centers for Health mechanism. Did a lot of literature search, a lot of community consultation. Stage 2, we've been able to validate the model, had some continued NARCH funding, worked with the National Congress of American Indians Policy Research Center. NARCH is specific NIH funding for tribal funding for tribal PIs. We partnered with the National Congress of American Indians. Then we were able to test measures from the model, begin to identify promising and best practices. Stage 3, we refined the measures and we then were able to test again. So all in all, we have actually tested our measures on 415 actually NIH and CDC and other federally funded research partnerships. They could be R01s, they could be AU mechanisms, they could be other CDC mechanisms or AHRQ mechanisms or PCORI mechanisms, but that all were testing. We were able to test our partnering measures on this huge variation from different populations and health issues across the country to identify best practices across the nation. And we are now involved in stage 4, where we're beginning to look at institutional barriers to authentic engagement. And Morehouse School of Medicine and Prevention Research Center is one of our partners. So this is the model. It embodies lots of literature in it, and that's why it's so text heavy. But to be honest, you can go back and look at it later, and you might have seen publications. It really is a pathway model looking at 4 major domains. It says that context matters, the local context, the national context, could be global context of COVID matters. And that leads to thinking of who are you going to partner with? Who are the diverse stakeholders in the partnership that are part of that context that make a difference to solving issues in that context? So the partnering and the processes of partnering matter, leading to then the choice of the action boxes, this orange red box that we call the action box of what you do. This is where the research design happens, where evaluation design happens, where strategic planning happens, where an intervention is developed. But if you're partnering, it's done with people to then develop this together. And then together, you can have outcomes based on your specific grant deliverables, such as enhanced diabetes management or uptake of screening or whatever the actual health issue is. At the same time, there's capacity building, there's partners developing more research skills, there's sustainability of the partnership, there's policy change. There's a whole range of social justice outcomes that are part of this domain of outcomes. So it really opens up the picture to think of a pathway of change. As we moved forward in our Engage for Equity process, we began to develop measures. And for context, in terms of the partnering measures, we initially developed measures about who's approving research, the red here. What is the level of historic trust and mistrust? What's the level of partnership capacity? And then what's the history of organizing in the community? Context we began to see was more identifiable through a lot of secondary data sources on socioeconomic status of a community, but also on qualitative understandings of what are people's sense of the place, the history of institutional racism, the culture. This became a qualitative inquiry into history, in addition to some quantitative measures that we developed for a survey instrument for partners. The partnering processes part of our instrument, our survey instrument that we've developed that you take on an internet-based platform, is quite extensive. That's where most of the measurements actually exist in our instrument, are in partnership processes or practices. And you can see there's the individual characteristics of the PI, of the team, of the community partners working with you. There's also the relationship practices of people, whether people believe that in answering this instrument, whether there's trust or respect, whether they believe, community members believe they have influence and voice, how much the partnership is engaged in authentic dialogue and listening, conflict management, leadership, ongoing reflection has become an important part of recognition as a best practice. And you'll see that in a few minutes. I'll take you to some of our identified best practices and resource management. Now you see two colors here. The red is the initial instrument we developed. And then as we headed with the first round of internet surveys of 200 partnerships around the country, the blue is then we had a chance to refine the instrument, recreate it in Spanish. It's translated into Spanish, actually also in Portuguese, but Spanish in this country. And we were able to then add to and create an instrument that embodies both of these together. Now, the structural issues here are becoming very, very important in our analysis. It's definitely who you're working with, the diversity of stakeholders in your partnership, and it can be others. These are just examples of types of stakeholders, but it's also how the structures of co-governance are realized, such that are there formal agreements between partners, between a Department of Health, a school system, a tribe, or another community-based organization? What are the formal values that have been adopted? Is there bridging social capital? And that's where members of the community are actually in the academy and vice versa. How is the control of resources? And of course, dollars to the community partners matter. And so you've got these both relational processes and structural processes that have begun to make a difference in how we see best practices. And these are measures that we have. They're available on our website. You'll be able to download them as you want. The next stage, this action domain, this kind of mixed domain of processes and outputs, has three very important sets of measures. How much is the intervention centered in the culture, fit, and history of the community itself? Really an important set of questions related to culture-centered interventions. The next set of questions is, what's the kind of belief or perception of the synergy between people leading to then the ability to produce outcomes? And of course, a very, very important for research, a very, very important set of questions related to how much is the community engaged in research in every step along the way. And these three types of questions or scales are in the instrument that can measure these three important constructs. Then, of course, outcomes, we have, as I suggested before, a set of long-term health behavior, health status changes, and maybe future policies or social transformation. But in the intermediate, can the university and community environments adopt policies that will make a difference in how the work is being done? Is the partnership sustained? Is there stronger community voice in research? Is there growth in skills and capacities of the partners in your community advisory boards, in your decision-making boards, in your that working with you, in the people on your team, not your participants in the research or in an intervention, or not your subjects, if you call them that in your intervention, but this is the team of people working together. And of course, your research outcomes become also important for those of us concerned about tenure and promotion in the academy. So that's the type of measures we've developed on every step along the path of the CBPR model. So just to share, and I'm going to take you through two sets of outcomes. One is a little bit of our promising practices and outcomes that we've analyzed in relation to the internet surveys of 400 partnerships. The other is a set of our tools that we use for workshops. So we have what we call an Engage for Equity toolkit from these three NIH awards. There is a website here, engagefореquity.org, and you can go on it and click on any dimension of this octagon and see a set of activities for how do you realize your principles, how do you look at your history with the river of life, how do you use the model for visioning for your own planning, strategic evaluation. And then there's a survey instrument, there's interviews and focus guides. Of course, every partnership has its own processes of self-reflection and self-evaluation. So this is just another set to add to your toolkit. So reflecting on your own partnership data, we have a partnership data report from our surveys. and using the Promising Practices Guide. We've actually put together a guide of the promising practices from the 400 projects. So just a couple of examples. This is a paper published in 2019 from the original set of partnerships that we surveyed in 2009. And you can see a set of them. I've just highlighted 3. The community engaged in research action as a practice where the community is engaged in all stages of the research originally came from Dmitry Koryokov from UCLA and RAND, working in mental health collaborations. He called it the CERI index, CERI, but we added action because we added a whole set of questions around what you do with the results of your data, and is the community involved in those actions in terms of policy change, in terms of sending a testimony for policymakers, in terms of dissemination in the community, and in terms of articles, etc., presentations. Is the community involved in national presentations? So we added a whole set of questions and therefore created a research action index. This one we found to be very important, that increasingly formal agreements are helpful in consolidating the processes of trust, which is, of course, one of the major issues that we all face in doing community engaged work. And then this one, commitment to collective empowerment, I highlighted. It has 4 different scales attached to it. I'm going to talk about it a little bit more, but you can go to this article and see a range of up to 20 promising practices we identified from the earlier set of outcomes associated with our composite outcome. We also recently published an article called on structural governance, and a measure, a multidimensional measure of structural governance. And we divided the work by looking at native focused projects and non-native focused projects. So you can see, if you look down this column, that more native focused projects actually have a higher percentage of projects who commit themselves to structural co-governance. That makes sense because they're governments. And it makes sense that they approve the research on behalf of the community, for example. They not necessarily have more community advisory boards, but on the whole, we actually were disappointed that only 47% of our 179 in this sample had community advisory boards. So it's still an aspiration to have community advisory boards. Native focused decision-making by community was almost double the non-native decision-making, including in hiring, in sharing financial resources, and in sharing more than just financial resources of the dollars in a subcontract, but in resource sharing of many other types as well. So this structural governance metric is positively associated with the CERA index and with commitment with collective empowerment, which is associated with outcomes. So to talk a little bit more about collective empowerment, it's a construct that is statistically coming together with 4 other scales. One where you share a sense of principles. We call them the CDPR principles. Those are the ones we asked about. You may have your own value set that you would want to know if they're shared by community, agency, and academics as you work together. That the members of the team in the community advisory board or just your joint team of co-researchers believe and perceive they have influence in the decisions, that the intervention, the research, the processes you use fit with the local history knowledge of the community, and that you engage in ongoing collective reflection. Together, these equal this construct of collective empowerment. And we recently came out with the structural equation model and Fuzzy said paper just recently that shows where collective empowerment sits in a pathway analysis. So collective empowerment, of course, if you go across the model from context to partnership processes to intervention research actions to outcomes with projected outcomes, future outcomes, and partnership transformation as more intermediate outcomes, you see collective empowerment fits with a relational pathway leading to synergy, as well as being associated with community engagement and research actions. If you're committed to collective empowerment, then you will engage community more in your research actions, leading to your outcomes. Yet also structural governance. These are all statistically significant. Structural governance leads as well to this pathway of structural commitment to community engagement in research actions and then future outcomes. So this is kind of the analysis we're doing of the importance of measurement of whatever particular project you're involved with, or at least engaging in some sort of assessment to see what are the pathways of best practices that are leading to outcomes. So now I want to just go back and say, in addition to the survey instruments, we also have tools and resources that we've been using to strengthen partnerships at the project level. And they're based in this Freirean reflection action praxis modality, where if we really are truly listening and we're truly engaging in dialogue and taking action, those research and intervention actions, then that's going to lead us to ongoing deeper listening, engaging in dialogue with our partners in action. And this kind of cycle is this collective reflection cycle that's kind of constant for us in those as we do community engagement and try and develop research based on this collective reflection. So one of the tools we've used for collective reflection, this is actually one of my research projects, family listening project with three tribes. Now we've expanded it to 6 tribes, but this is 3 tribes coming together, a Pueblo tribe, Apache tribe, and a Navajo tribe, to share their own history of how they came together. Here's a Navajo hogan, here's the Pueblo image, and an Apache image that they chose as a teepee, coming together with different circles to a collective engagement together and the production of a very community and culture-centered family intervention for children, parents, and elders to really decrease risky behaviors of kids and improve their connection to culture and language. So this has been going on, this project, for over 20 years with multiple funding cycles. We also use the model here as a visioning time. This is a Detroit Urban Research Center project. You can see the model got transformed here into a circle. It didn't stay, but it was an attempt. This is a strategic way they were thinking of it. This is a model created in Sweden. I'm sorry, there's some back, but this is a model for a Swedish health promotion project. Sorry about that extra sound, working with immigrant Muslim communities. So this model is being used in Germany and Brazil and other parts of Latin America to create strategic thinking about how to create your own pathway for change. So we see many versions of the model. So given that we have this period of time where we were looking at projects at the individual level and how to strengthen them, what are the best practices? How do you measure these practices? How do you look at practices related to outcomes? We began to realize there were limitations, challenges, that individual projects can't do it alone, and that they and we don't have sufficient support from our own academic health centers and even those very wonderful community engagement cores to sustain authentic, equity-based patient and community engagement. Obviously, and you probably have seen it in your own communities, there's still ongoing distrust of academic health centers by community members. And what we began to identify as a national team and a team out of UNM, that we didn't really have the ability to test engagement interventions at the research infrastructure level, at the institutional level, at the academic health center, and even the knowledge of how changes at the research infrastructure level can then impact or support or strengthen their community academic partnerships and patient community health outcomes. So we began to look at the whole big picture beyond just individual best projects and their best practices. And we developed a grant called E² Plus. It is an ongoing PCORI engagement award. It's our university, University of New Mexico, with Stanford, Fred Hutchinson, University of Washington, Cancer Consortium and our wonderful partner, the Morehouse School of Medicine and the Prevention Research Center, and led by the team there of Dr. Akintobi and LaShawn Hoffman, working with us to kind of test the feasibility of strengthening institutional research support for equity-based, and because it's PCORI grant, patient-centered outcomes research, community-engaged research, CBPR approaches, we were lucky that we could have a partner that already has a Morehouse model of community-based participatory research. So that was a great boon for us. But the aims of this grant have been to conduct institutional assessment of practices, processes, and norms to equity-based PCOR, CENR, and CBPR, and then to test the feasibility of what we now started calling E²+ with enhanced engagement. And we identified this strategy of working with champion teams at the institution level, but a team that would be comprised of not just academics or staff, but also community partners and patient advocates. And together we would go through a set of Engage for Equity or E² workshops with our River of Life, with our visioning with the model, with our identifying kind of the new targets of change at each institution, and ongoing meeting with the champion teams, coaching, learning from each other. And the third aim was to co-create a community practice with the 3 participating institutions. And we've been able to actually learn quite a bit. We actually had this wonderful opportunity in June to co-present together our work over the past year and to learn how each institution was thinking about institutional targets of change and practices at the institutional level that could support their community engagement projects, independent research projects, new pilots, however you wanted to support the ongoing community engaged work that investigators and community partners do together. So what was this, or what is this E² approach? That we would use our evidence-based Engage for Equity tools, workshops, measures, collective reflection, we hope, ongoing to scale up institutions, working with champion teams, workshops for more than 25 people at each place, a set of workshops. We also conducted the first institutional survey in each institution of about 35 people of current policies, practices, beliefs and barriers, and facilitators of change. We conducted some beautiful community and patient advocate and investigator focus groups and incredible leader interviews where the leaders really expressed their important kind of vision for how community engagement, how equity, how anti-racism fits within their institution. We then brought back that qualitative data to the champion teams and to each other in another workshop. So we had a set of workshops, first before the data and then after the data. We finally are getting, I have to say, we keep hoping it's coming out, our full institutional survey results going back to each of the institutions to look at the quantitative data on policies and the beliefs of how much CBPR practices, community engaged practices, and are in place and what still needs to be brought forth. And we have and so then we fostered this multi-institution community of practice. So I just wanted to raise, if you're very interested in this E² approach across the state of Georgia, you have your expert here in the room, Dr. Akintobi, her partner, LaShawn Hoffman, and other members of her academic team from the Prevention Research Center and Morehouse, who could talk to you about that next step. We're moving towards the Science of Engagement Award. We just submitted our letter of intent to test this approach with 8 other institutions, but we'll be continuing our community of practice with our 3 institutions. You can see kind of a timeline here. We've now started our 2nd year of the grant. So I just wanted to thank our partners for Engage for Equity. We've had our UNM Center for Participatory Research, Community Campus Partnerships for Health, the University of Washington Indigenous Wellness Research Institute and their School of Medicine, We work with the folks from the University of Waikato in New Zealand, RAND Corporation, and the National Indian Child Welfare Association. I'm trying to have this think tank, a collaborative think tank over many of these patterns of NIH funding. And again, just I will provide this slideshow to you if you want. There's two websites really. There's of course my own email, but it's a website at my Center for Participatory Research, and then the engageforequity.org website, which is outside the institution. So I think I'm going to have time actually for conversation and dialogue, which I was hoping for, and time for just, I just want to mention two other things. We have this extended long survey that we had the research projects, obviously through NIH funding, where we tested every dimension of the CVPR model. Context, as you saw, more limited, practices a lot, and intervention and research, and then outcomes. We've been in the process of shortening that instrument to what we call our FIRE, P-H-I-R-E instrument. It's also in Spanish, Fuertes, Partnership for Health Improvement for Research Equity Survey. It only takes 10 minutes to do. It's shorter instrument that partnerships could use. And I've been testing it also with coalitions, with health councils, with departments of health working at a community level, not just with big research projects. But the idea that you might want to think about taking this on, and I've working with a young kid who's just graduated college to create a web app where a PI can go on and select the instrument they want and put the partners in that you want to take it and monitor it yourself, and then get your own partnership data report, an Excel spreadsheet, aggregated, not by individual person, aggregated anonymous spreadsheet for your own analysis. So that's the goal, is to create a self-sufficient or a self-guided or a self-usable tool or instrument that different partners can test out and try and see if it makes them go straight in the direction that you want to go. So I should have created a slide there on that, but I realized it's still in process, but I'm hoping in the next couple of months, we're going to have that web app up for people to test out. For both the longer version and the short version.
Thank you so much, Dr. Wallerstein. You've inspired us, and hopefully there'll be some per Dr. Escoffery's invitation who will put your questions or comments in the chat at this time. And certainly folks can also unmute to share any comments or questions that they have. So I'm happy to warm things up. The Georgia Center for Diabetes Translation Research is really to advance health equity research in the kind of T3, T4 space. So many of the folks who are learning about the center in its second iteration, we're, I think, walking into year 2 of a new 5-year funding cycle. Many of the people who are here or are interested in the center may be hearing for the first time what CVPR is, or community-based participatory research, and that there are rigorous metrics related to the partnerships and processes that you described. So I want to start with asking this question, and that is, are the metrics and the measures that you described, Dr. Wallerstein, are they limited only to people who officially describe themselves as community-based participatory researchers?
Well, we've had when we actually surveyed the 400 plus partnerships around the country, we actually used the reporter database and looked for research where there was some form of engagement mentioned in the abstract somehow, but it was with a great variety. It might have been more intention to engage. It might have been very much at the end of, okay, yes, we're totally doing research, shared leadership. So wide continuum. So yes, it's been tested on a wide continuum of projects. Now, whether it's been tested on T1 research per se, I can't say. I do think that there are always in T1, T2, T3, T4 research, always stakeholders that are always end users. I hate the term end users, but I'll use it anyway. there are always stakeholders and constituents to consider and potential partners in the framing of the research question. And it's very exciting to me to extend this continuum into what community engagement really can be. And that the fact to even think through, what does it mean even for a T1 researcher to say, I'm going to think about how I do research with. What does that mean? It's a very simple question, but it challenges us, and to say, well, who are the stakeholders that, and can there be a small group of key informants, so to speak, who can sit with me and help me frame my research question that then we will do in the laboratory. They won't be involved in doing it, but they will frame the question. They'll frame the gaps that exist in delivery of care, or they'll frame the need in a big way, because that's where the CBPR definition really states that community members or stakeholders frame that the research is based on needs and priorities framed by that group. So I think it's a tremendous potential leap for T1 researchers to jump into. What would it change in terms of how I frame the question? Even if I know it's moving on, in a very deliberative way from my previous research in the lab, what would I gain from having this dialogue with a set of key informants, not just who are going to sit with me one time, but who are going to sit with me over time and challenge me. And well, you have to love being challenged. If you wanted, okay, I'll just have to say that you have to be a T1, T2, T3, T4 researcher who loves being challenged. That's what you have to be. But other than that, you don't have to be anything else.
Great. And I see a hand raised by Mega Shaw, Dr. Shaw.
You're on mute, Dr. Shah.
Sorry, got it. Thanks for such a great talk. I really enjoyed it. I had actually two questions. The first was, so I do some community engaged research here in Atlanta, working with certain immigrant communities that hadn't had as much experience working with academic researchers. And, I think what ended up, at least in my journey, was that I realized early on in the process that we needed to spend a whole lot more time in capacity building to make sure that we were all on the same page. And I would love to hear about your experiences with, we always assume that communities they want to be engaged and they want to challenge us, but we also need to make sure that everyone's on the same page. And sometimes that involves a lot of capacity building around what research even is, and what is a research question, for example, right? So really basic things that a lot of my community partners had not had any experience in. And so I'm curious about your experience with capacity building of community partners, and how you have kind of supported that through, your team has clearly been very successful in continuing to have extramural funding, but how you have kind of navigated that with funders. My second question is, some of the work that you're doing now, it sounds like also thinking through some of the institutional barriers to conduct community engaged research. And I'm just curious if you could share some examples. So some things that are challenging for me here at Emory is HR. I work with a population that is predominantly immigrants. So a lot of their degrees, for example, are in another language from another country. And when I want to hire somebody for a job, they don't have a degree that they can submit to HR that HR will accept. So like something simple as that. Or trying to complete city training for a community partner who wants to be involved in every step of the research. And so I'm curious about kind of any examples you have of ways that you've navigated some of those institutional barriers. So thank you.
Well, all of that is challenge. All of those are big questions. And, there's not one answer, but I'll just kind of say where I think about it. So in the capacity building, it's a slow process. And when you often form early relationships, you have one or two people that you've connected with, or you've connected with them through proxy trust. Somebody else said, oh, Dr. Shaw's a good person. Yes, she can come and talk to our community CBO board or whatever. It's kind of, and then you begin to acquire. So when I started working with, for example, one of the tribes I was working with, I had one contact. I had a social worker in the health department who then introduced me to someone in the diabetes program, who then introduced me to someone in the senior program, who then, and one of my teams actually two Native colleagues of mine who took a year walking from program to program in one of the Apache communities where the programs were spread out, trying to identify, people to work with. And we initially called, we've been in this trajectory ourselves of calling the group we work with a community advisory board or a community advisory committee or whatever. And now our committees are all co-researchers. We call them tribal research teams. So we have a UNM research team and we have our tribal research team, TRTs, and we come together as teams together, and we're all collaborating it. But that's a 20-year process. And so, sometimes it's a small group of 5 people are meeting and they say, well, wait a minute, where are the elders? And then you bring the elders in, or they say, wait a minute, where are the youth? And then, well, oh, okay, we'll do a video project with the youth. And that involved all these high school kids. And so sometimes there's some natural progression. In terms of some of the core research skills, we've actually done, Research 101, but we've often started with, what bad research. We've started with examples of, and especially if they tell us that they've been involved in research that's not gone well, or we say, there's history of research, and you kind of unpack together, and you say, yeah, this is not a neutral term. There's a lot of history here. And this is what we want to do something differently. This is how we want to do it different. So you acknowledge and have dialogue about negative. I'm a supporter of having open dialogue. And you kind of say, but in terms of, for example, the city training, we've discovered the Harvard Catalyst training. Have you used that? And we just did a training of 11 of our partners, a new tribe that we're working with. They have never done research in a way we're doing it. And we had 11 of them together go through it. And then they all got their certificates together, because you do the exam, you do the questions together. It's not like an individual. It's not hours and hours of wrenching time alone on the computer for your community partners. You do it together, and then they all took a picture with their diplomas. It was like this major achievement, and it took 2.5 hours. You sound like you've done that. For Native communities, there's also a whole Indigenous city type training produced by the University of Washington that's been tested in R01. And so for that, it's a longer process. Harvard Catalyst, you can do it. We've also reframed the Harvard depending on the community we went for examples. So for the African-American community in Albuquerque, we gave examples of history in terms of research in Black communities. For the Latino community along the border, we gave examples of the Latino history, and for the Native. So you can change the Harvard Catalyst slideshow as well to add your own examples, which is what we've done. The institutional, so yes, capacity building matters, and recognizing that it's an evolving process to really have a strong partnership and showing up. And then there's another community city training that Dr. Escofri just put in this chat. So yes, these are beginning to be recognized, but you have to get them recognized by your own IRB, which is of course one of the challenges at each institution. It's like we have to do it one by one by one. Why can't we do this by NIH saying these are recognized trainings, instead of every institution having. So yes, there are many institutional barriers that are common, and HR is one huge one. And actually our 3 institutions have not been dealing with that one. They have been dealing with IRB issues and around having community members on the IRB and community review and et cetera, they've been dealing with long consent forms and, really inappropriate kind of things for community engaged research. They've also been dealing with finances. How do you, the post-award structures at most universities are very anti community engagement, not by directly or overtly, but just because of the policies are set up to be reimbursement instead of funding up front. There's all kind, or just a lot of difficulties of hiring community staff and as consultants. I think, and if we can establish, I'm hoping through extended working across the nation of a couple of best practices at the institution level, and then get them mandated by NIH as that universities have to follow them, that would be to me a huge advance. Because again, it's like you just said, one investigator like yourself going to your own HR and saying, please, it doesn't make sense, so it's kind of, how do we begin to look not just at partnership best practices like we've been doing before in the Engage for Equity work that hopefully are getting out, and the structural ones are getting out, but institutional best practices hopefully too. And there's a lot of them. You're absolutely right. Lori Carter Edwards came up with a really nice article. She was at UNC, now she's at Kaiser Medical School. I'm not getting the name right, in LA. Someone knows, maybe knows. But she just came out with a really beautiful article on administrative and financial barriers at the institution level. And so again, trying to get that out in the literature is what we hope to do too. But big questions, yeah.
So Nina, I had a question about, I love this whole concept of the, making sure I say it right, the collective empowerment. And you have those different domains. And one of the ones I was really interested in was the collective reflection. Can you talk more about that, and how is that operationalized? Or
Well, we go from long scales to short scales because people get exhausted with long scales. So the instruments that we have are for partners. They're not for like your community or patient respondents of or participants in an intervention. They're for the partners themselves. So we've now, I think, gone to 3 questions of what is collective reflection. One, first question has to do with, do you do ongoing evaluation of your partnership? So, in whatever way you do it, you might do annual retreats of your partners. You might do your own survey, self-survey. One tribal partnership I was working with in the Northwest in Washington, state of Washington, was doing weekly meetings, and they would do a meeting inventory. So, so they have an ongoing reflection. So that's one. The other is, do you have a commitment to equity and to addressing equity in your partnership? So just kind of more directive. It's not inherently in the name collective reflection, but a commitment to equity. And I think the other one maybe is just about ongoing opportunity, not evaluation per se, but ongoing dialogue within your partnership around your partnering processes, et cetera. So it's kind of like which, I mean, I've been very interested in collective reflection because it's part of a Paulo Freire approach to work in the community, and what does that dialogue mean? But I haven't really found measures of collective reflection. So we identified, but maybe I could find it real quickly what they are, as if someone else wants to ask a question.
Well, while we tee up a final question or two, Jeff Mills has put the link in towards you applying to be a member of the Georgia Center for Diabetes Translation Research. All of these webinars that we have through the center are designed to advance the art and the science of advancing diabetes health equity. And so the ways you can learn more about what's coming up if you're going to that is by going to that Smart Shape sheet, and you'll get more information regarding the center at large, and certainly webinars like this that are facilitated by the socio-ecological core and the other cores of the center. So, Com, do you see any other questions or comments sent in the public or private chat?
So I can show the 3 questions. I had one of them wrong. So
Oh,
let
good.
me just show that quickly. Hold
Wonderful.
on. So this is our partnership data report where it defines it. Evaluate and reflect on your own partnership processes to seek continual approval, recognize the challenge of addressing issues of equity, power, and privilege. So partnership has discussions about our role in promoting strategies to address social and health equity. Our research partnership evaluates together what we've done well and how we can improve. And then our partnership reflects on issues of power and privilege within our partnership. We had a longer scale before, but this is within our, can you see it move my? Or
Yes.
is it-
Yes. Yeah. we see
Okay,
it.
so this, I know this will be kind of, don't close your eyes for a minute. This is our partnership data. Anyone who takes our survey, again, this web app will spit out a partnership data report, which has a table of contents of context, commitment to collective empowerment, processes that are structural, processes that are relationship, intervention, research, design, and outcomes. And we've created sort of a summary of your partnering practices. Who approves the partnership? Do you share control of resources? Formal agreement, yes or no? Dollars to community. And then we call them thermometers, but this is just a generic one, where you are from a Likert scale of not at all to complete in having shared CVPR principles, that the principles fit and the community fit the community, partnership values, leadership, etc. And then each one, context, there's kind of a explanation of context, but each one you get your own scale and your own data by your own thermometer. So it's trying to make a user-friendly. It's long because there's a lot of scales, but these are the actual questions in the scale of the longer version. And then the shorter version, of course, has only 30 questions instead of 100 questions. So this is context, partnership capacity, final approval, no, none, here, etc. collectively. Okay, so we're trying to create tools that are open for groups, partners, or new community engaged pilots who might want to use them also.
Thank you
Thank
so
you.
much.
Yeah, that's going to be invaluable. And I love the whole idea of your own printed report. So thank you for that. Somebody just asked, are the links to the tools available yet?
Yes, so engageforequity.org has the existing tools. It doesn't have the shorter instrument up yet. We're still refining. I mean, we've been testing it in different venues. It has the long instrument in RedCap. It's a little wonky, the PDF, because it's got the English and then the Spanish and can't have all of the kind of bridging, questions when they go to other questions. But yeah, engageforequity.org or my Center for Participatory Research has the tools up too. Engageforequity.org has a bunch of videos though around the use of the model, the use of River of Life. It's all public.
Thank
So
you so much. Thanks so much, Dr. Escoffery, and she's put the link in the chat, and also thank you, Dr. Wallerstein, again. Jeff, when is the next webinar for the center?
It is September 21st. I'm going to share my screen in just a second. We have a slide for it. So this is going to be with Ashley Walker from the University of Florida, using technology to reach underserved communities with diabetes. So we look forward to that talk. And this one is actually going to be in person. So we'll start communicating that in the weeks to come, and we'll have food and stuff like that. So looking forward to it.
Thank you, Jeff. Thank you, Dr. Wallerstein, for your insights, your partnership, and your leadership over time. We look forward to you